I'm going to start PowerPoint number 7, Hospital Inpatient Record. So we're just going to go through the different things that are in a hospital inpatient record. We're going to start off with the clinical data. This includes all healthcare information obtained about a patient's care and treatment, which is documented on numerous forms in the patient record. So we'll start off with the emergency room. So the emergency record documents the evaluation and treatment of patients that's seen in the facility's emergency department for immediate attention of urgent medical conditions or traumatic injuries. So the documentation they need of the assessment, the treatment, reason for the patient's disposition. Now disposition is where they went. Were they admitted? Did they get discharged, or were they transferred elsewhere? And you also need a copy of the discharge instructions provided to the patients. If they came in by ambulance, there also needs to be an ambulance report created. Patients that are transported to the emergency department via ambulance will have an ambulance report generated. So the EMT is the one who starts it. They document any clinical information, their vital signs, how conscious the patient was, the appearance of the patient, and anything else they feel necessary to document. And then a copy of that report is also placed in the emergency department record. The original, though, is property of the ambulance company. Anti-dumping legislation. This is started up here where it is Emergency Medical Treatment and Labor Act. This prevents facilities licensed to provide emergency services from transferring patients who are unable to pay to other institutions. It may require that a patient's condition must be stabilized prior to transfer. So what does the Joint Commission require? I'm not going to read through all this, but as you look, they require a lot. They want to know the patient's identification, time, and how did they get there? You know, they come by ambulance. Did somebody have to bring them in a wheelchair? Were they able to walk? Their history, physical findings. Was there any care provided prior to arrival? Diagnostic and therapeutic orders. Any clinical observations. Reports of procedures, test results. Diagnostic impression. And conclusion at the termination of evaluation. And then again, final disposition. Where did they go? What was their condition? Was there instructions? Make sure you look against or through examples for an emergency room and also against medical advice. This is when a patient leaves, and what they try to do, they try to get them to sign a form saying, hey, this really needs to be signed. We don't think you should be leaving. And then it's got to be documented in the progress notes. An appropriate filing system must be established for storage of ER records. They need to combine them with inpatient and outpatient records. Okay, so let's start here on the discharge summary. Keep in mind a discharge summary, clinical resume are the same thing. It depends too. Usually you only hear discharge summary, but some older school hospitals still call it a clinical resume. So what it does, it provides information for continuity of care and facilities medical staff committee review. Because again, they'll take this discharge summary because it is usually the whole patient's hospitalization, the course of their treatment, and the condition at discharge. It must fully and accurately describe the patient's condition at the time of discharge, patient education for self-care. So what are the whole contents of a discharge summary? Well, you have patient and facility identification. Admission and discharge dates should be at the top. Reason for hospitalizations. Again, you see chief complaint, history of present illness. Significant findings. Did they find anything in the lab? The x-ray. Did they take a biopsy? So that would be in the pathological. And what treatment was rendered? And then finally, when they left the hospital, what was their condition on discharge? So again, there should also be instructions to the patient and family There should be a diagnosis, procedures, of course the signature of the attending physician, and then possibly in the event of the patient's death, a summary statement should be added to the health record either as a final progress note or a separate resume. So the final progress note can be documented instead of a discharge summary, let's say just for a minor problem or defined by a short stay. And if they are transferred to a different level of care, then that's going to be called a transfer summary. So let's say they went right into skilled care or right into, ICU. The conditions of participation state that all records must document a discharge summary, including the outcome of hospitalization, the disposition of the case, and then any follow-up provisions. So make sure you read through your examples in your book. Find your own examples in the bullets. Again, you won't be doing this. I just kind of have this in here. Some people have charts, they like to find examples. History and physical examination. Okay, the history is a record of information provided by the patient concerning his or her chief complaint, present and past illnesses, personal and family histories, and review of systems. Now let's start off here with the medical history. This should be obtained by the patient, and if possible, and document only facts. It is the responsibility of the attending physician to take this history. An interval history. It documents a patient's history of present illness and any pertinent changes and physical that occurred since a previous inpatient admission. If the patient is readmitted 30 days after discharge for the same condition. Okay, let's talk about the history. Okay, remember, the review of systems is not a physical exam. It is the patient telling the physician their problem with that system. So again, a lot of people get the review of systems and physical exam mixed up. So with review of systems, for respiratory, the patient's going to say, I've been coughing a lot. Now, if this was the examination, the doctor's going to say, oh, in their lungs, I hear a rattle. Okay, that's the doctor doing the exam. The patient's going to tell them what's wrong. So again, for history, the patient could say, my throat is sore. That is the patient telling the doctor. Now, if the doctor's examining the throat, the doctor's going to say, the throat looks red with white spots on it. That's the examination. So the physical, after the history is completed, then the physician will do a physical exam. They are going to assess the body systems, and this will help determine a diagnosis. So again, you could have a provisional. This is what initially they come in for. Differential, again, abdominal pain versus appendicitis. Physical. One thing when you look at a physical on a history and physical form, keep in mind a history and physical form is going to be when the patient's getting admitted to the hospital. They do a history and physical. Discharge summary is when they get discharged. So when the doctor does the physical examination, they should not use terms as negative and normal. They should be used only when summarizing stated facts. The physical exam is a responsibility, again, of the attending physician. It is appropriate for house staff to perform it and dictate the report. The attending physician reviews the report to be sure it's completed. So what are the standards? The Joint Commission states that H&P must be performed and documented in the patient record within 24 hours after admission. This includes weekends and holidays. So if a H&P was completed within 30 days prior to admission, reviewed, updated, it can be placed on the record within 30 days prior to admission, reviewed and updated. The Medicare COP states that evidence of a physical exam must be performed within 24 hours after admission and filed on the record. So again, let's look for documentation for a physical. I may be off on the page number, but what you want to do, you want to find some examples again. The lungs are clear to what? So again, you want to make it chest is normal. Well, what is normal? Consultations. Okay, this is the provision of healthcare services by a consulting physician whose opinion or advice is requested by another physician. A consult report is documented by a consultant, includes the consultant's opinion and findings based on physical exam and review of the patient's record. So let's go with a consultation. It's a request for a specialist. So we have an internist and the patient's having chest pain. So they call in a cardiologist for a consult. You have an internist with a patient having a hard time urinating or pain urinating, and they're just not sure exactly if it's a UTI or it could be something more serious. And at that point, they call in a urologist. The consulting physician may participate in the care or even possibly just take it over. So again, they're going to examine the patient, review the patient record, examine the patient, document findings, and then possibly recommend or give their opinion. The Joint Commission and the AOA standards state that medical records shall contain documentation of consult reports. So again, you won't find it right now in your records, but it will be part of the assignment. Okay, so then we have physician orders. Again, these are going to be direct diagnostic, therapeutic, patient care activities. Medications could be in order. How often should they change a dressing? Clear, complete. It has to be legible if handwritten. Again, dated and timed, and then it needs to be authenticated by the physician. The Joint Commission requires medical records to contain diagnostic, therapeutic orders, and verbal orders to be authenticated again by the responsible physician. The facility will have medical staff, bylaws, rules, and regulations. And then we just get in there for different types of orders. You're going to have computerized ones. And make sure you review the type of orders in your textbook. And again, the page numbers may be off. We also go to progress notes. These are statements related to the course of the patient's illness, a response to treatment status. They provide a chronological picture analysis of the patient's course. They document continuity of care, which is very crucial to the quality of care. So different notes. You have an admission note, a follow-up note, a discharge note. How often do you document them? Well, it depends on the patient's condition. The patient's stable, probably once a day. If it's at the beginning of their stay, it could be up to 3 times a day. And again, make sure you go through all the different types of progress notes. Dietary notes too must be documented before the patient eats. You want to make sure you know if they are, should have a low salt diet or sugar. Anesthesia, you should have pre and post. And it gives you pre and post operative notes. Again, pre is before, post is after. Integrated progress notes, these are all in the same section. Go ahead and read through the progress note standards. And again, just kind of with all these, everything needs to be dated, time, and written by the attending physician to make them valid. So if there is any questions over this PowerPoint, please send me an email.